Hello, Assalamu alaikum. Hello, everyone. Hello, Dr. Basim.
وعليكم السلام. This is Dr. Basim. Do you hear me?
Please, if your voice is clear, please. Okay. معلش دكتور بس أساس نعبي السلفي بعدين نخليها جنبنا. تمام
ألو
دكتور؟
ألو
Hello, Dr.
Do you hear me? تسمعوني؟
Yes, we. Dr. First, we will apply the survey. Okay. Please, from your all, okay, that's about the. It will take just 5 minutes. After that, we will start, inshallah. I already sent the link on the chat.
ألو ألو
You hear me?
لا، الصوت راح. ألو
Hello, Dr. Hello, Doctor. Do you hear me now?
أيوة اسمعك الآن.
Okay.
احنا
So
لايف اونلاين ولا لسه مع المجموعة؟
we are live. I will reply what I say. Please all. This is the survey just about the national person for the patient safety day. Please apply it. It will take just 5 minutes. I already sent the link in the chat. 5 minutes, inshallah, we will start. Walaikum salam for all the new arrive. Please the survey about the patient safety day. Apply it after minutes. Dr. I already sent the link in the chat. Dr. Bassem, you can start now.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Good afternoon, colleagues. It's a pleasure and honor to be with you today. Um, and thanks for the Saudi Patient Safety Center for inviting me to be with you. Um, Today, we are celebrating the World Patient Safety Day, and this year theme is about healthcare worker safety. And as you know, we are in the COVID-19 pandemic. So the organizers have asked me to talk about IBC measures in the context of COVID-19 and also to talk about workforce safety. The outline and objectives of my talk will be focusing on three main issues. Of course, the first one would be the IBC core components and the minimum requirements for the IBC core components at national and facility levels. And then we'll be talking about the IBC measures in the context of COVID-19 with some focus on safety of healthcare workers who are providing care to COVID-19 patients. As you may know, there is a lot of data that's have been available so far 8 months now into the or 9 months into the pandemic, but data so far indicate that COVID-19 infections among healthcare workers seems to be greater than those in the general population. Of course, we have data availability issues, and even the quality of the data available has some limitations. But while healthcare workers globally represents around 3% of the population, and in some countries, in low middle income countries, even less than that, it seems like the prevalence of infection among healthcare workers it seems like infections among healthcare workers have been reported as 14% of the total cases of COVID-19, and in some countries up to 35% of infections occurred in COVID-19 are among healthcare workers. So this is really alarming compared to the prevalence in the total population. We have been in WHO commissioning some literature review, and there is a currently ongoing systematic review on this issue on COVID-19 infections among healthcare workers. But so far, it seems like that certain exposures with direct patient contact and certain aerosol generating procedures and direct contact with bodily secretions are associated with increased risk of infection among health workers. So far, the data in the data, there is no association between demographic factors like age, gender, or healthcare worker rule even, and the risk of SARS-CoV-2 infection. The infection, COVID-19 infection or SARS-CoV-2 infections were observed in various hospital departments and healthcare workers with different rules. So again, there is no specific associations except the ones that I've highlighted in the first bullet. And also, on the other hand, the findings indicate that personal protective use, whether masks, gloves, gowns, and eye protection together, and in addition to hand hygiene, are or have been found to be associated with decreased risk of coronavirus infections. So the appropriate use of personal protective equipment and appropriate hand hygiene seems to provide some protection to healthcare workers against getting the COVID-19 infection. Also, recently, as you may know, WHO has issued guidance requesting or recommending universal masking in healthcare facilities, particularly in areas where the wide community transmission is present and overcrowding is unavoidable. So in those healthcare facilities, WHO recommends universal masking, and this has been found also associated with decreased risk of COVID-19 among health workers. Additionally, also it has been indicated that if the healthcare workers have received specific IBC training, this has been also associated with decreased risk. So all of these data takes me to the important point here today, which is the importance of IBC as part of patient safety and also as part of healthcare worker safety. Infection prevention control aims to prevent harm to patients, to health workers, and even to visitors from infections. And also IBC is an integral and essential component and element of quality of care, of patient safety, of even health security, and also aims to reduce the problem or the issue of healthcare associated infection and the ongoing global threat of antimicrobial resistance. So IBC has a very central, very fundamental role in this pandemic, and also in protecting both patients and healthcare worker safety. Similarly, and interestingly enough, the first global patient safety challenge, which is a patient safety global call for actions, was really about reduction of healthcare associated infections, which is the main role of infection prevention control teams and workers and experts through improvement in hand hygiene in healthcare. So this is, again, all of this indicate how important is IBC for patient safety and for healthcare worker safety. Also, data indicates that IBC is very important to improve patient outcomes. There has been evidence that effective IBC programs lead to 30% reduction of healthcare associated infection rates, of course, and also reduction of morbidities and mortalities associated with these healthcare associated infections. Surveillance of healthcare associated infection contribute to reductions of occurrence of those infections, and many other data, either organism specific or program specific, that indicates infection prevention control has contributed to reduction of harms and also has improved patient outcomes, and of course saves lives, costs, and also provide quality of care, improve the quality of care of patients. WHO, in collaboration with many international organizations, have also produced specific guidance, evidence-based guidelines on core components for infection prevention control at the national level and also at the facility level. These are evidence-based recommendations and some good practice statements based on evidence from low middle income countries and also high income countries. These are 8 core components that should be available at the facility level and 6 core components that should be available at the national level in order to achieve effective IBC programs and in order to achieve what I have been saying about improving patient outcome, improving safety of healthcare workers and improving the quality of care. I don't have time to go through into the details of these core components, and WHO has produced lots of guidelines, document, and implementation tools so that countries and healthcare facilities can adapt or adopt those core components, but I will briefly highlight some of the important ones. We have been working with countries, particularly low middle income countries, on implementation of these core components, where we produced as a step in the effort of countries to reach for the full implementation of core components, we produced some guidelines on the minimum requirements. These are the first early steps that countries and healthcare facilities can start with till they have worked on more ongoing approaches to achieve the full core components. In the next few slides, I will just briefly go through these minimum requirements. For example, at the national level, as I said, we have 6 core components of IBC. There should be an IBC program at the national level with at least one full-time trained IBC focal point and a dedicated budget. For there should be a national IBC guidelines, which is evidence-based, that cover the main items of infection prevention control and adapted to the local context and reviewed periodically and updated periodically. The third is there should be a plan for education and training on IBC for all healthcare workers and all specifically for IBC practitioners in the country. There should be a working group looking into how to start implementing surveillance of healthcare associated infections and how to monitor IBC practices in the country. The fifth minimum requirement is related to what we call the multimodal strategies or integrated approach, implementing all of this into an integrated approach, which we call it the multimodal improvement strategy, which should be implemented to improve IBC intervention at the national level. And the last minimum requirements is about IBC monitoring, auditing, and feedback, where there should be an IBC audit tools, monitoring tools, plan to start auditing practices and implementation of IBC in healthcare facilities and feedback those findings to healthcare facilities with support for improvement. These are the minimum requirements at the national level. At the healthcare facility levels, in addition to the 6 requirements that they have that are should be available at the national level, similar to those should be available at the healthcare facility level, in addition to these 2, number 7 and number 8, which is workload and staffing. And this is again important for our topic today, which is health worker safety, and also very important for patient safety as well, that we should reduce crowding and establish triage and patient flow systems, and also improve staffing levels as part of our efforts to improve infection prevention control. Patient-nurse ratio, patient-doctors ratio, in some words, this needs to be well proportionate, and also to avoid overcrowding and in the workplace. The other one is enabling environment that has the minimum infrastructure for infection prevention control, for water, sanitation, and hygiene, for hand hygiene, and also infrastructure and supplies for personal protective equipments, which is a lot of talks and works have been done since the start of the pandemic on personal protective equipment supplies. We all know that we have globally shortage of personal protective equipments, and this is very important, integral part of infection prevention control. But not all infection control is about personal protective equipments. Also, sufficient infrastructure in the facility in the terms of single isolation rooms, if not available, then cohort areas, and availability of these cohort areas to be used when similar situation like the COVID-19, which we have, where we can host patients with similar clinical symptoms all together in one place if we don't have single isolation rooms. So these are the minimum requirements at the national and or at the healthcare facility level. As I said, the first step to start working on building the national and facility level core components for IBC as per the WHO recommendations. Let me now switch to my second topic, which is about infection prevention control strategies to limit the spread of COVID-19. I think before going into the details of those measures, let's talk a little bit briefly about how the current COVID-19 is transmitted, particularly in healthcare. This is what's known, and for epidemiologists and IBC practitioners, very familiar chain of transmission of infection in healthcare facilities, and it is true also for community transmission as well, but we use it in this example to highlight some of the important measures that we need to act on. We have the infectious agents. In our case, it's the virus, the SARS-2 coronavirus, and which is usually present in a reservoir in patients and also or in contaminated services and equipments, and through some port of exits in case of patients, of course, the respiratory droplets. It gets out of the patient's reservoir, and through particular modes of transmission, which I will be cover in a minute, will get access to portal of entry on the susceptible host, in this case mouth and nose of a susceptible person, whether healthcare worker or another patient in the healthcare facility or in the home or in the family, and this is how the transmission cycle continue to work, and this is how we get infection transmission and we get outbreaks and unfortunately pandemics like the COVID-19. The importance of, let me go back, the importance of chain of transmission is by identifying these elements, we can definitely have one or more option of interventions to limit and to break this cycle and to limit the transmission of infection. Currently, according to the available data, the current COVID-19 or the current SARS-CoV-2 virus is transmitted mainly by droplets. It's transmitted mainly by droplets, which is the respiratory droplets occurs during sneezing, coughing, and or loud talking, for example, and this is the main route of transmission. There is also a minor and a less important route, which is the direct contact of contaminated surfaces and equipments, and very, very minimal role of airborne spread, particularly specifically during what we call the aerosol generating procedures or procedures associated with high volume of aerosols. These are particularly in some particular medical procedures like suctioning, open suctioning, like cardiopulmonary resuscitation, intubation, extubation, and so forth. So only during these particular situations we need to be more careful, and we in WHO think that these require additional precaution particularly during these aerosol generating procedure. For all the rest of other routine medical procedures, droplet precautions and direct or contact precautions are sufficient to protect healthcare workers. Let's move now to what WHO recommends for countries and healthcare facilities as measures to limit the spread of COVID-19. 5 strategies: screening and triage, so that we can early detect cases and do rapid source control measures. I will come back to those in a minute. And then apply standard precautions for all patients. Implement additional precautions, in this case, droplet and contact, and whenever applicable and during, as I said, aerosol generating procedures, to apply airborne precautions. Of course, this is as part of the package of isolation and cohorting, then implementing administrative controls and implementing environmental and engineering controls. And I will try very quickly to go through each one of those very quickly. As I said, these are the multiple strategies we use in order to break the chain of transmission at several levels to prevent and limit the transmission of COVID-19 in healthcare facilities. We don't want the healthcare facility to be the amplifier. We don't want the healthcare facility to be the source of transmitting the infections to patients, to healthcare workers, and unfortunately to the community, which has happened in many situations, unfortunately, and has happened also in previous outbreaks and pandemics around the world. Example, Ebola and MERS-CoV. So healthcare facilities, we should spend all the efforts to limit the spread in the healthcare facility. Secondly, to prevent that healthcare facility from being an amplification factor or a transmission hub or epicenter to transmit infection to other places. So very quickly, the first one is triaging, and triaging should be part of a whole cycle of managing patient with suspected and confirmed COVID-19 in the healthcare facility. And triage, as we said, is very important at the point of entry to that healthcare facility, whether this point of entry is the emergency room or the outpatient clinic or the other areas that patient first encounter when they come to the healthcare facility. In primary care, for example, it might be the outpatient clinics, it might be the entry even to the primary healthcare facility. In the hospital, it might be the emergency room and so forth. So these are the points of entry of healthcare facility. We should install screening and triaging in those areas, and put specific signs to tell people in their own language, in their understanding culture, that if they have respiratory symptoms, they should be separated, they should be isolated, they should go to somewhere else, not mix with the rest of the patient or visitors coming to the healthcare facility. These are some tips about how we can practice this triaging. Of course, we need to maintain physical distance to the best possible, and it would be very good idea to have a physical barrier between healthcare workers and patients or visitors coming at those points of entry to the healthcare facility, also to prevent direct contact with patients. And no PPE is required at this stage if that particular patient doesn't have respiratory symptoms, and respiratory hygiene and hand hygiene are recommended. For patients themselves, if they have respiratory symptoms, they should inform, of course, the healthcare worker, and if they can tolerate, the healthcare worker should ask them to put in mask and should ask them to be away and put them in a separate dedicated area till they be fast tracked and consulted with medical consultation can be done to them. They ask them to adhere to respiratory etiquette. I will come to respiratory etiquette in a minute, and also perform hand hygiene. And in this case, if the patient have respiratory symptoms, then healthcare workers should use at least the droplet precautions measures like medical mask, gown, gloves, and eye protection, and of course always perform hand hygiene. The second strategy that WHO recommends is standard precautions, and standard precautions, I'm sorry that the slide is not moving well, but the element of standard precautions are hand hygiene, personal protective equipment according to the risk, waste management, safe injection practices, respiratory hygiene, environmental cleaning, safe and appropriate handling of linens, and environmental and disinfection and decontamination of equipments, and waste management. These are the elements of standard precaution that should be practiced with all patients in all times by all healthcare worker facilities, by all healthcare workers in all healthcare facilities. And let me tell you frankly that through our reviews of data received from countries about infection among healthcare workers, these are most probably the lacks or the breaches that end up with exposures of healthcare workers, because in most of the situation, healthcare workers don't know whether the patients had COVID-19 or not, and they don't practice standard precautions, so they get this exposure and this contact with patients that have the disease without practicing standard precautions, so they end up with unprotected exposures. Um, uh, 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 as we said, it's very important to apply risk assessment for standard precautions all the times. This means, in addition to hand hygiene, what sort of personal protective equipment we should use in standard precautions. I will come in a minute to talk about that in more details. Hand hygiene, very important, very useful, and also very cost-effective measure that has proven to be effective in limiting the spread of many infectious outbreaks in healthcare facilities. And it is very true also for COVID-19 pandemic as well. WHO has been working and teaming with international organizations and international societies to promote hand hygiene in healthcare facilities, and even in the community. There is the theme or the call of hand hygiene for all, and I think WHO is and UNICEF is working about that. There has been a call for countries to promote hand hygiene more and more in healthcare facilities, but even beyond and out of healthcare facilities, to promote hand hygiene in the community and make available either soap and water or alcohol-based hand rub in public places, public buildings, and other similar buildings and gatherings. WHO has produced many guidelines and implementation tools to promote hand hygiene. The famous 5 moments for hand hygiene, I don't have time to go through them, but this is a very essential part of standard precaution, but also true as part of specific precautions for COVID-19. Again, either alcohol-based hand rub or soap and water will be very useful to clean hands in healthcare facilities and even in the community. Respiratory hygiene, this is an essential part again of the standard precautions that healthcare workers and patients should practice in healthcare facilities. We are now approaching to fall and soon to winter, so respiratory hygiene and hand hygiene together can protect us a lot from all respiratory infections, including COVID-19, but not limited to, but expanding also to influenza and other cold viruses and organisms. This is achieved through covering nose and mouth with a tissue when sneezing or coughing, and if there's no tissue, then we can use our sleeves to contain the secretions of sneeze and cough, and then we clean our hands with soap and water or alcohol hand rub afterwards, and also we put the tissue of used in appropriate waste. Patients with fever and cough and sneezing should be kept at least 1 meter away from other patients, and we should provide visual aids for patients and visitors to practice respiratory hygiene. And if the patients and visitors tolerate, we can ask those with respiratory symptoms with coughs and sneeze to wear masks while they are in healthcare facilities till they've been medically checked. The third measure is to apply additional precautions in addition to standard precaution if we suspect or confirm that the patient has he or she has COVID-19. As I said, we apply droplet and contact precaution to all patients with suspected and confirmed COVID-19. We apply only airborne precautions only during aerosol generating procedures. That's the droplet precaution. Simply, we keep the patient in a separate area, limit their movement, put specific signage, use appropriate personal protective equipment, and also assign specific teams of healthcare workers. There is no need to have all healthcare workers into the patient room, only those with the specific functions. Dedicate the equipment if possible, dedicate furnitures also if possible, and perform appropriate environmental cleaning and appropriate communication to patients and their families. So this table summarizes the different measures, precaution measures for all routine medical procedures with COVID suspected and or confirmed COVID-19 patients. We apply as a healthcare worker. We use medical mask, gown, gloves, eye protection in the form of goggles or face shield. We ask healthcare workers to not to touch their eyes, nose, and mouth while putting personal protective equipments, particularly during patient care, because that might be contaminated. We ask the patient to wear medical mask if they can tolerate, and both healthcare workers and patient, they should perform hand hygiene. We put the patient in a single room if possible. If not, then we cohort all the patient together, and we maintain good ventilation in the areas and rooms where patients are kept. Only during the specific aerosol generating procedures, here are some examples that we apply only the airborne precautions, and very simply we replace the medical mask, or sometimes in some countries it's known also as surgical mask. We replace the surgical / medical mask with N95 or FFP2 or what we call the particulate masks. These of course should be fit tested, very importantly, and the rest is still the same: the gown, the gloves, the eye protection, either goggles or face shield. And again, we ask the patient to put mask if they can't tolerate and perform hand hygiene. So this is another example where we can rationalize actually the use of personal protective equipments. We have seen in many situations healthcare workers wearing N95 masks for non-aerosol generating procedures. So please, the message is to rationalize the use of personal protective equipments based on available evidence. Routinely, we use medical mask, gown, gloves, eye protection to care for COVID-19 patients. We replace only the medical mask with an N95 mask if we are performing aerosol generating procedure. Let me very quickly, the third part, let's be talking about the health worker safety, and with particular focus on personal protective equipments. And I have seen at the start of this meeting that the colleagues at the center, they asked you for some feedback on PPE use. So it might be actually good coincidence that we talk about personal protective equipments in a little bit of more details. We have in healthcare, gloves to protect the hands, gowns and aprons to protect the skin or our clothes, and masks and respirators to protect mouth and nose, and eye protection in the form of eye goggles, and face shields to protect face, mouth, nose, and eyes. These are basically most of the PPE. Of course, there are others, but these are the ones that mostly used. And very importantly, that we know that there are three factors that influence our selection of which PPE or which PPE combination that we should use. The first important one is the type of exposure anticipated, and the category, whether the procedure which we are going to do will have or will be associated with splashes or sprays or contact with blood and or body fluids. The second important category in this is which category of isolation or precaution measures or additional precaution measures are we in? For example, in droplet precautions, or standard precautions. So this is another level of importance or factors that determine the use of personal protective equipment. Another important factor in our selection is the durability and appropriateness to the task. As said, for example, in the previous slides, we don't use N95 for routine work of COVID, for routine medical procedures with COVID-19 patients, but we of course strongly recommend using N95 during aerosol generating procedure. So this appropriateness to the task is very important. Another example is, for example, we have seen many healthcare workers using coveralls to care for COVID-19 patients in healthcare facilities, where coveralls have been mainly designed and more appropriately used while taking care of Ebola patients, for example, or hemorrhagic fever cases in the community, not COVID-19 patients in healthcare facilities. So this is another appropriateness of the task example. And the other factor, important factor, is the fit. And here, for example, every healthcare worker should know his or her size of gloves, his or her size of gowns, face shields, goggles, and so forth. So the fit is very important, and this particular fit becomes even more important when we are talking about particulate respirators, or, for example, the most commonly known as N95 and other respiratory protection personal protective equipments. So gloves for patient care, we have several varieties: vinyl, latex, nitrile. We have sterile for surgical procedures and non-sterile for other medical procedures. One or two pairs, usually two pairs of gloves are probably indicated in, for example, procedures which associated with huge splashes of blood or body fluids, like some orthopedic surgeries, some gynecological surgeries, and so forth. But in most medical practices, and in our case here, the COVID-19, one pair of glove is indicated. And of course, single-use gloves are preferred, and we don't recommend reuse of gloves. Some of the important tips for using gloves: to work from clean to dirty, and to limit opportunities for touch contamination. Whenever you use your gloves, don't touch your face, don't adjust your other personal protective equipments, don't touch the other environmental services except if this is part of patient care. Change gloves when they are torn, when they are heavily soiled, and very importantly, after use on each patient. And probably, again, this is another level of rational use of personal protective equipments. We have this debate a lot with many healthcare facility and many healthcare workers in situations where we have cohorted patients together in one ward, for example, COVID-19 patients. It's very important to change gloves between every patient, because we don't want to transmit other organisms that might be colonized or infecting those, particularly the antimicrobial resistant organisms. So very importantly that we change gloves after each patient use. In some situations, of course, if it's torn or heavily soiled, even on the same patient. And of course, we need to make sure that we dispose those in and appropriately, either in the healthcare facility or as a terminal disposal. Gowns and aprons, of course, we have different designs and different purposes, reusable and disposable. Again, we have also gowns or aprons that are resistant to fluid penetrations, and particularly the coveralls. The example I mentioned, these were more fit for Ebola situation, but for our COVID situation, we used regular gowns with not necessarily to have high fluid resistant or fluid penetration index. And of course, these could be clean or sterile. Mostly sterile ones are used in surgical procedures as well. Face protection, whether mask, in some countries they call it surgical, other countries they call it medical mask, to protect nose and mouth, should also have some fluid penetration. So paper mask is not appropriate. Other masks, a closed mask is not Hello, do you hear me? Okay, great. Thank you, and very sorry about this. I was disconnected all of a sudden. Um, okay, so I was talking about face shields as part of the personal protective equipments. Um, 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 So these cover forehead and should extend below chin and wrap around the sides of the face. The eye goggles also is another alternative to protect the eyes, but should snugly um, fit very firmly around the eyes. Uh, for your note, personal glasses, they don't substitute the eye goggles. Some eye goggles, of course, they have the anti-fog feature so that they reduce the vapor from our breath. Um, so these are very quickly and some of the personal protective equipment. Let's also talk about the respiratory protection ones, and they should protect from inhalation of infectious agents. And we have the particulate respirators, and mostly or most commonly known as the N95 masks, but we have alternatives to those, and we start to see them becomes more and more available in healthcare facilities, although they were mainly available in research laboratories and academic institutions. But we start to see them more and more in healthcare facilities, like the elastomeric respirators and the PAPR, or the powered air purifying respirators. These ones, if you have seen them in some places. And so these are the ones that provide more respiratory protection from infectious agents, from inhalation of the infectious agents. As we said, their role in COVID-19 is only limited during the aerosol generating procedures. It's very importantly that remember the third factor in selecting our PPE is the fit for the size, and this is particularly important for particulate respirator or the N95 mask. We should do, of course, annual fit check test, but if this is not done, and because of the COVID-19 pandemic, at least we do the what's called the seal check for before each use. So we put the N95 mask of our size, we put it firmly, and then we do exhale sharply, and positive pressure inside the respirator means that there is no leakage. And we do also the negative seal check. We inhale deeply. If no leakage, then negative pressure will be make the respirator clinch or in depth into your face. So this is very important seal check that all healthcare workers should perform while using before using the N95. So again, this is another example of appropriateness to task. You don't want to use N95 mask for routine procedures, because it's really will affect your breathing, and it requires specific measures before use, and of course after use. So in summary, some of the key important personal protective equipments notes that we should always remember: these are procedure specific. They are produced and manufactured specifically for medical procedures, not to be worn all over the shift or all over the day or so forth. They in design, they have been manufactured to be used before contact of the patient or start of the procedure. Of course, because of the shortage of COVID-19, there has been some debates and arguments and discussion around extending and expanding the use of those personal protective equipments. I will talk about that in few minutes. While using the personal protective equipments, we should limit service and items touched, as we said before. We should use those carefully in order not to spread the contamination, because they can get contaminated very easily, and we should remove and discard them carefully, and always perform hand hygiene. In some situations, we do hand hygiene after each removal of each piece of personal protective equipment, particularly if we are in, for example, a COVID-19 ward and not an isolation room. Another important principle is the issue of contaminated and clean areas of personal protective equipment. We consider the outside and front side of personal protective equipment as always contaminated once it is worn, while we consider the inside and the outside of the back of the personal protective equipments to be clean, although if we extend their use in healthcare facilities, this wouldn't really actually be standing correct. WHO has produced lots of online courses on use of personal protective equipment in the context of COVID-19 and also on IBC measures. At the end of my presentation, I will share some of these links and some of these courses available. And these are free and self-paced, so healthcare worker can register and enroll and navigate at his or her or pace to listen to and enroll to these courses. I don't have time, unfortunately, to talk in more detail about this topic, how to put on and remove personal protective equipment because of the time. A couple of thoughts about extending the use of personal protective equipment, particularly the surgical masks and the respirators. WHO has been working with many centers and organizations and healthcare facilities around the world on this issue. Currently there are some research going on ways to, for example, decontaminate some of the particulate respirators on the N95 respirators, but these are still trials, not finalized and not being peer reviewed and not being evidence-based yet. So once these are available, WHO will definitely communicate the results to countries and healthcare facilities. What's available so far is safe use of what's available so far is we can extend the use of surgical masks to some extent, and also we can extend the use of respirator up to 8 hours of continuous or intermittent use. But with this, I would personally suggest to rationalize the use of personal protective equipment from the beginning. As I mentioned, for example, limit the number of healthcare workers entering the areas or rooms of COVID-19 patients, rearrange the procedures so that one healthcare worker can do more than one procedure when he or she enters the room, limit the movement of healthcare work of patients outside their isolation areas, so that we minimize also the use of personal protective equipment and so forth. There are many options to limit the to rationalize the use of personal protective equipment, and WHO actually has released some guidance on this, so I will put it also at the end of my presentation. Again, these are continuing on the same theme. Limited use of masks or respirators have become torn, or they become contaminated, or they lose their integrity, which is very important. Before I close, let me also continue on the healthcare worker safety issue. So in addition to following the IBC measures that I have talked about, using the personal protective equipment appropriately, there are still some administrative measures that can help also healthcare workers to be safe. For example, adequate training for healthcare workers on IBC measures and also on other factors related to managing COVID-19 patients, ensuring sufficient patient to staff ratio, active syndromic surveillance, and actually WHO will be releasing soon guidance on managing healthcare workers for COVID-19. Some of the important things that we strongly recommend is if the facility can afford to conduct active syndromic surveillance of healthcare workers at the facility entry, like measuring temperature, measuring whether they have respiratory symptoms or not, because in some situations we have found outbreaks occurring in hospital not because of patients suspected and or confirmed with COVID-19, but because unfortunately of healthcare workers that they haven't declared their conditions and they have respiratory symptoms, they had respiratory symptoms and they mixed with patients and healthcare workers infecting their colleagues and their patients as well. Ensure healthcare workers and public understand the importance of seeking medical care promptly and to monitor healthcare worker compliance with standard precautions and provide feedback and improvement plans, working with healthcare workers to improve their compliance with personal protective equipment and other IBC measures. So these are known as administrative measures. Additionally, also environmental and engineering control measures are very important. As I said, it's very important if that we install physical barriers between health workers and patients, particularly importantly in the triage and the screening areas, like an emergency room, like in an outpatient clinic. The first place is the point of entry to the healthcare facility. This is very important. Environmental cleaning and disinfection. WHO has released some guidance on disinfection, cleaning disinfection in the context of COVID-19. This is the link. Unfortunately, I don't have time to go into the details of that as well. And very importantly, maintaining adequate ventilation according to specific areas in healthcare facilities. In most of our countries, we are still in summer and we don't have natural ventilation capacity to maintain good ventilation in our healthcare facilities. Most of our healthcare facilities are or have mechanical ventilation systems. So we need to make sure that, that we have adequate ventilation, we have adequate filtration, we have adequate fresh air pumped into our healthcare facility in particular areas to reduce opportunities of contamination and transmission. So with this, I think I came to the end of my presentation. Here are some online courses that WHO is providing through Open WHO. It's free, as I said, and self-paced. So my apology if the font is not clear, but I will leave a copy of the presentations with the colleagues at the center to, if they have the capacity to disseminate to you. And also here are some references and WHO guidance and their links so that if you wanted to have more information on the topic. With this, I would like to thank you very much, and my apology for the internet disruption. Thank you very much, and over to you, colleagues.
Thank you, Dr. Basim, and thank you for all the attendees. See you, inshallah, in the next lecture. Goodbye.